Hi, Kristen. How are you?
Oh, hi, Richard. I'm great. How are you doing?
Doing fabulous. Thank you so much for taking time out of a very busy schedule to talk to us this morning. And I'm delighted that on this episode of Rare Awareness Radio, we are joined by Dr. Kristin Baranano, and she is joining us from Johns Hopkins University, right outside Baltimore, I guess, is probably where we find you this morning in the greater DC metropolitan area. So once again, thank you for coming on and speaking with us this morning.
Oh, it's my pleasure. Thank you for inviting me.
Usually what I love to do to kind of start the ball rolling is, folks don't know who you are yet. So I would love for you to just take a few moments, introduce yourself, Dr. Barignano. Let's talk about where you trained, your areas of interest and expertise. And then certainly we're going to probably talk a lot about CACNA1A
Mhm.
and that gene and your role and how you're working to work towards some cure and remediation for that.
Sure. So I am a child neurologist and a neurogeneticist. I am in Baltimore, Maryland. When I was an undergraduate at the College of William and Mary, I was a pre-med major and I studied developmental biology and I researched early patterning in the central nervous system. And so I knew I loved neuroscience. And when I came to Baltimore nearly 30 years ago for the medical scientist training program at Johns Hopkins, I knew I wanted to study developmental neuroscience, and child neurology seemed like a natural fit. Fortunately, it turned out that I did love working with kids. Um, so for the combined MD PhD program, people typically spend 7 or 8 years with this, with the goal of developing clinician scientists. So the first 2 years are medical school, and then the years in graduate school studying basic science, and then return to medical school to finish clinical rotations. And my PhD research studied genes that control how neurons make early connections in the developing brain, primarily in mice and rats. I then spent 2 years in residency training as a pediatrician and then 3 years as a child neurology resident. And as child neurologists, we are board certified in adult neurology with special certification in child neurology. So even though we specialize in children, we're equipped to follow children into adulthood. And I also will evaluate adults who have neurological issues and developmental disabilities that have their roots in childhood.
Mm.
So, after spending a year as a general child neurologist in Atlanta when my husband was finishing up his fellowship, we came back to Baltimore and I was a neurogenetics fellow at the Kennedy Krieger Institute, which is an institute for children with developmental disabilities that is affiliated with Hopkins.
Mm.
And it was around this time that I realized that I wanted to use my training to translate basic science into the clinical care of individuals with neurogenetic disorders
Mm.
instead of running my own lab.
Mm.
So I developed an interest in a movement disorder called ataxia, which is incoordination that typically comes from problems with a structure in the brain called the cerebellum, which is located at the back of the brain. And it's really important for fine tuning and coordinating our motor inputs so that our movements are adaptive and accurate.
Mm.
And it was because of my interest in ataxia that I started caring for and diagnosing individuals with CACNA1A related disorders.
Mm. Kristen, it's so challenging to be a pediatrician, period, right? Children are, I'm a dad, you're a mom. It's hard to they can't advocate for themselves. They often can't describe symptoms that they're feeling, or it's so challenging to be a pediatrician. I can't imagine the challenges associated with being a neurologist, a neuroscientist, specializing in pediatric care. There's a lot of challenges just associated with CACNA1A, how it's diagnosed, how those related disorders are diagnosed. We've certainly talked to many parents and caregivers who have been on these large diagnostic odysseys. Can you talk a little bit about maybe your approach, Kristen, to the diagnostic process? I'd love to hear that.
Sure. So I just wanted to give you a little background about kind of CACNA1A to
Sure.
set the
That would be great.
stage, just to understand what it's doing in the nervous system and how it causes these symptoms that we see in children and adults. It encodes what we call a voltage-gated calcium channel.
Mm.
So our neurons are electrically excitable cells, and so when an electrical impulse reaches the tip of a neuron, the voltage change causes channels like CACNA1A to open and allow a rush of calcium into the neuron,
Mm.
which binds to the synaptic machinery and results in the release of neurotransmitters.
Mhm.
So CACNA1A is particularly enriched in the cerebellum, and many people with CACNA1A experience ataxia as a symptom.
Mm.
So when we have a pathogenic variant, or what sometimes people call a mutation in CACNA1A, it can result in either underactivity or overactivity of the channel.
Mhm.
So classically, the loss of function causes a condition called episodic ataxia type 2, where people have attacks of imbalance and incoordination, which can be associated with dizziness, eye movement abnormalities, headaches, and nausea and vomiting. Overactivity of CACNA1A can cause a condition called familial hemiplegic migraine type 1, where
Mm.
people can have migraine headaches that can be associated with weakness in one half of the body. These can be very serious and even associated with swelling with one half of the brain and seizures. There is a completely different kind of change in CACNA1A, what's called a triplet repeat expansion, that causes a form of progressive ataxia called spinocerebellar ataxia type 6. Over time, we've learned that changes in CACNA1A can also cause epilepsy, which can be severe, and also congenital ataxia, where children have motor delays and often low tone or hypotonia. And as development progresses, it becomes apparent that they have cerebellar ataxia.
Mm.
In any of these situations, children can have language and cognitive delays, which in some situations translate into intellectual disability.
Mm. We've talked a little bit with Adam Clatworthy, right, and others who have had issues with epilepsy and the common sort of misdiagnosis, I guess, really with epilepsy as part of this, Kristin.
Mhm.
Can you talk a little bit about, again, sort of the steps involved in your diagnostic process? And then I kind of want to flow right into your approach to genetic counseling and how families are affected by CACNA1A mutations.
Sure. So in my neurogenetics clinic, it's very common for me to be evaluating children because they have concern for developmental delay, or they
Mm.
may have epilepsy that's difficult to treat, or a movement disorder. And so, in terms of the initial steps, first, there's always a thorough history and an examination, both kind
Mhm.
of general and neurological. And then we determine if something like brain imaging, like an MRI, is necessary. For children with CACNA1A, they'll often need a brain MRI to look for other potential causes of neurologic symptoms, such as abnormal eye movements and their low tone,
Mm.
because we can't immediately jump to the conclusion that it's caused by something like CACNA1A.
Mhm.
But in these kinds of situations, we typically move on quickly to genetic testing, which is necessary to establish a diagnosis of CACNA1A related disorders.
Mhm.
And so in our clinical practice, we would typically offer either whole exome sequencing or whole genome sequencing that looks through the spelling of all 20,000 of our genes. For children or individuals who have episodic symptoms like episodic ataxia or hemiplegic migraine, we might do more targeted testing of genes, so something called a panel that
Mm.
might include CACNA1A. With these genes can be associated with this group of disorders. And for sure, insurance coverage can be a serious obstacle to some families in getting a diagnosis. And so, as part of the evaluation in the neurogenetics clinic, I work very closely with a genetic counselor
Mhm.
who's very involved in the process of drawing out a family tree to see if there are any neurological conditions of note that seem to run in the family. And
Mm.
sometimes we'll find out that a parent or a grandparent is affected. And in
Mm.
that situation, there is a 50-50 chance that each child will be affected, depending on whether or not they inherit that copy of the CACNA1A gene with the change.
Wow.
With CACNA1A, it's very common for family members to have differences in how severe their symptoms are.
Mhm.
In other cases, it turns out that the child has a de novo or brand new change, which
Mhm.
means for when the sperm or the egg was being made, a change was introduced when the DNA was being copied. And in this situation, the likelihood of having another affected child is very low.
Hmm. Interesting. Interesting. I wanted to ask you about the odds, so thank you for giving us the sort of notion around the 50%. I've certainly talked to families who have had multiple children, some children affected, some children not affected, right? So it's very interesting to see that. When you are thinking and working with parents now about the current treatment options, the different management strategies that are available for patients with CACNA1A related conditions, Dr. Baranano, what are some of the sort of, if there is such a thing as a standard approach, is there a standard approach, or is it really a sort of like up from start each time you have to have
Mhm.
a very customized approach to what you're doing?
Yeah, so right now our management typically focuses on either preventing symptoms or treating symptoms when they occur. So
Mm,
for example, a child might be on a seizure medication to prevent epileptic seizures, or they might be on a medication to help migraines or episodic ataxia attacks.
mhm,
And then we work with families to identify potential triggers for events to help reduce the frequency and severity. And then for children with developmental delays, including motor delays, therapies such as physical therapy, occupational therapy, and speech therapy are super important and helpful.
mm. Is there anything related specifically to um, management? You said management of symptoms, of course, right? But the condition itself and sort of any other, you mentioned PT, OT, speech therapy. Where do you kind of, is it always a multidisciplinary approach, I guess, Dr. Banyara, is what I'm trying to get at. I would assume the answer is yes, but I just would love to
Mhm.
hear your kind of thoughts on that.
Sure. It is absolutely typical and expected that a child with CACNA1A is going to have a team.
Mhm,
It starts, of course, with their parents, who are their biggest advocate, but then their pediatrician, their neurologist, and often a developmental pediatrician. And then they have their therapists, including their PT, OT, and speech therapists.
mm,
And then in the school based setting, their teachers, too,
mm.
and aides that might be involved in caring for them and helping them at school.
That's perfect. Thank you. Thank you. We probably would be remiss if we didn't talk a little bit about the ongoing research that's being done, the clinical trials. You and I both know that these rare or underdiagnosed conditions often don't get the attention, right, from the research community or the clinical trial community. But can you talk a little bit about some of the developing therapies that are either sort of in process or de novo or rising up as it pertains to CACNA1A related disorders?
Sure. So the CACNA1A Foundation, which
Mhm,
started about 5 years ago, has done an absolutely wonderful job pulling together researchers and clinicians to kind of tackle these issues around CACNA1A.
mhm,
And so some of the issues they've prioritized are what's called variant curation. So trying to understand how a specific DNA change affects the function of the gene so we can make better predictions about how that effect is going to manifest and how to manage it and how it might respond to different treatments. And then they're working on disease models in mice and other organisms and things, something called iPSC cell lines.
mm,
There's a natural history study, and we're working on developing clinical management guidelines so that all the different people out there who might run across and be taking care of individuals with CACNA1A will know the best practices in treating this disorder.
mm,
We're also working on baseline clinical assessments so that we can follow kids with time and have measures to know if potential treatments or interventions are actually helpful. And we're working on expanding access to promising medications, especially in children.
mm. Is there, I'm going to assume the answer to this is no, but is there enough sort of being done from a clinical trial perspective right now? We obviously talked to Sunitha Malapati and the work that they're doing at the CACNA1A Foundation. She has her other initiative, right, the Buffalo Initiative, which is trying to apply more of a venture capitalist sort of approach, right, to funding research in this area. I'd love to hear your thoughts on, are we doing enough? Are there enough clinical trials aimed at this, or should there be more?
So the short answer is there should absolutely be more.
Mm,
There is a database called clinicaltrials.gov, and that's our go-to resource to see if there are clinical trials that our kids with rare neurogenetic disorders might be eligible for.
mm,
And really, there is nothing out there right now for CACNA1A
yeah.
in terms of any kind of cutting edge treatments or therapies that we can offer up families when their child is diagnosed. And
Mm,
so, with advances in genetic testing, we've made really great progress in diagnosing these kinds of ultra rare genetic disorders, but having a diagnosis doesn't always translate into knowing how to take care of the individual with the disorder.
sure.
And so we really need ongoing partnership between families who are affected with researchers and clinicians to move the needle on understanding these disorders and finding meaningful treatments.
Mm,
There are thousands of rare genetic disorders that are competing for attention, and we're entering into the era where gene therapy is really starting to become a reality.
mm,
But the issue is that for many of these disorders, potential therapies are going to have to be tailored to each individual, and we need better ways to target those therapies into the nervous system.
mm. I can't imagine how challenging it is to think about the targeting and the personalization, right? The personalized aspect to this. Before we kind of jump into some of the advancements in neurogenetics as it pertains to precision medicine and personalized medicine, you did mention a minute ago the CACNA1A Foundation and sort of the resources and support systems that are available. Can you just opine, I guess, for a minute, Kristin, on how important, the connection for, if I'm a parent of a child that's recently been diagnosed with a CACNA1A disorder, where do I kind of turn to? I know we hear stories of parents spending hours Googling and trying to find answers. Do you have resources or support systems that are kind of your tried and true?
Sure. So having a specific diagnosis, it can be just hugely, hugely helpful for families so that they can find a reliable source of information and find families who are experiencing and dealing with the same set of issues,
Yeah,
really kind of comparing apples to apples, so to
sure.
speak. And so the, CACNA1A Foundation has been a wonderful source for our families. And then another really good resource for kids with congenital ataxia or episodic ataxia is the National Ataxia Foundation. They are also a really great, reliable resource.
That's great. I want to double back to the precision medicine aspect, Dr. Bagnaro, the personalized aspect. There are a lot of advancements in neurogenetics that are influencing the treatment and the diagnoses of rare neurological disorders. What are the ones that you're kind of most excited about, kind of paying attention to, maybe even looking at as part of your own clinical practice?
Sure. So, in broad strokes, there are two major ways to kind of think about editing and changing the genes that have variations or mutations.
Mhm.
And so we have these ASO type therapies, the antisense oligonucleotide therapies,
Mhm.
and then we have this CRISPR technology.
Right.
And so, ASO is a reality for disorders like spinal muscular atrophy for sure, and is really kind of been a game changer for children with this condition. And then for, CRISPR technology, again, it's been a lot of publicity lately about the child in Philadelphia who had a rare metabolic disorder that they could treat, but it was centered in editing their liver, so a
Right.
more accessible tissue than the brain, so to
Mhm.
speak.
Mhm.
So I think we're all very excited about these, really becoming realities, but very much limited so far by kind of the accessibility of the nervous system and having the infrastructure to tailor these therapies to each individual who might have their own specific genetic change. So these are kind of big questions that we're not quite sure how we're going to tackle this so far.
You mentioned CRISPR, and I guess from a layperson's perspective, right? That's the one we certainly hear about, like you said, highly publicized, and it's in the news, and certainly there was a big to do about it when it first sort of broke from the scientific community. I think it never really kind of synapsed with me until you just said it right now. Like from an organ systematic standpoint, your liver, other organs are much more highly accessible than your brain tissue. I think that's something that certainly was lost on me until you just said that right now. Yeah.
Sure.
Yeah. As you think about where we're going from here, Dr. Bagnaro, and some of the future terms of the research and some of the treatment, where do you envision, I guess, this going? You've been at this for quite a while now.
Mhm.
You've offered a lot of support to individuals. Is it more community? Is it more research? Is it more funding? I'm sure the answer to
Mhm.
is yes to all of the above, but I'm curious as to how you envision the terms.
Sure. So in my ideal world,
Mhm.
we would very quickly identify children with neurodevelopmental disorders and efficiently find their genetic diagnoses so that families can really avoid these protracted diagnostic odysseys that so many of them experience. And
Mm,
so then families can be connected with disease-specific supports and enroll in clinical treatment trials and have access to medications that we would know would be helpful in treating their disorders.
yeah.
Mhm.
Yeah. And then in terms of your lab and the things that you're kind of most excited about right now, John Hopkins certainly is known for leading the way in so
Mhm.
many aspects of medicine and treatment. Are there, and if you can't speak about these things, we completely
Mhm.
understand, but are there certain things that, you're working on specifically that are giving you a lot of excitement or hope and anticipation?
Sure. So as you can imagine, in terms of there being so many different rare genetic disorders, the ones that are receiving the most kind of attention and focus right now are those when individuals have progressive neurodegenerative courses,
Mm,
because these are, children who and adults who will be losing skills and their
yeah.
function over time.
Mhm.
And so these, are more time critical in terms of interventions. But I think everyone is increasingly recognizing the importance of more kind of static neurodevelopmental disorders and
Mm.
finding effective treatments for them as well.
Mm. And I have a little bit of training in cardiology, and I kind of go back to what you were saying about calcium channel, and
Mhm,
from a cardiology standpoint, you think of it as, oh, it's we're blocking those channels, and I'm curious as to some of the difference there for those of us who aren't neurologists about the differences you mentioned the calcium channel. I'm curious. It's all kind of coming together for me now.
mhm.
Yeah. How is that approach different in neuroscience, I guess, than in cardiology?
Well, so when we think about the different types of voltage-gated calcium channels, they break down into different families.
Okay.
And so the CACNA1A voltage-gated calcium channels in what's called the PQ family.
Okay.
You have T types, you have L types, you have PQ
Sure. Yep.
types.
Yep.
And so the issue is that we really don't have good medications that are specific for that
Mhm.
subtype of calcium channel. So the medications that you might think about that we use to treat like high blood pressure and cardiac issues, those are targeting more like T type channels and L type
Gotcha.
channels. And so there's a little bit of, it's not, there can be overlap between, the mechanism of different types. But one of the things we really need to focus on and something the CACNA1A Foundation is interested in is really looking at drugs that would be specific to that subtype of voltage gated calcium channel.
Thank you. Thank you for helping me to understand that. That's
Mhm.
great. Dr. Kristin Baranano, thank you for your time this morning. I really enjoyed speaking with you. All this tremendous work that you're doing, all this training that you've had. It's really quite remarkable. Thank you for talking to us about how you're approaching CACNA1A, its treatment, its management, and the work that you were doing. It's so important, and the special emphasis on pediatric neuroscience. I can't imagine the challenges, but the rewards that you must recognize on a daily basis. So thank you so much for spending some time with us.
Oh, thank you so much. It was my pleasure.